Thank you.
Thank you very much, Lorenzo. Thank you very much to the organisers for inviting us. I'm going to run through the Leicester series. I'm going to try and touch on a few of the more interesting topics, and then I'm happy to take any questions. I've no disclosures, I've no conflicts of interest. There are some patients shown in these slides, and they're all happy to do that. They've all consented to that. We've been doing this since 1994. We do total pancreatectomy for chronic pancreatitis. There's 2 patients in this series for recurrent acute pancreatitis, and this is done for small duct disease. 60 patients since September 1994, and we follow them up quite extensively, initially 3, 6, 12 months, and then annually for a minimum of 10 years, and quite a lot of them out to 15 years. We've got 2 prospectively maintained databases, which we've had for over 15 years now, so we have some good long-term follow-up. We do telephone interviews. We have a nurse specialist who's been with us from the beginning. And over the same period, we've done 43 pancreatectomies without islet transplantation, 8 of whom were originally scheduled to have an islet autotransplant, but we couldn't extract sufficient islets. The assessment, I think, of these patients is really important. I mean, in addition to the diagnosis of the condition and the investigations for that, we have a multidisciplinary team. These patients are seen by a clinical psychologist, a diabetologist, a gastroenterologist, and a pain specialist. And any of those people can veto the procedure. We used to get them to see a patient who'd had the operation more than a year ago and one who'd had one less than a year ago. But because our program is not funded for some time in the UK, we can't do the less than a year ago now. But that is very important. And we bring these patients back to a specific consent clinic. If you look at the patient details, they're principally females, they're slim patients, which is the only advantage of this procedure. It's a long operation. It takes us approximately 10 hours to do this. Part of that, of course, is the islet autotransplantation. We don't lose much blood. The median loss of blood for this procedure is about 700 ml, so it's pretty well tolerated. We've had one death. We've had one death in a patient at 36 days who had unrecognized carotid stenosis and had a stroke. Surgical technique straightforward, although we do pylorus preserving, which we like to do because of bile reflux gastritis, and we generally preserve the spleen. It's very uncommon for us to need to do anything about the spleen unless they've had previous surgery or unless they've had a pseudocyst. So this is what they look like. On the left is a pancreas that we have for an islet allograft. On the right is a fairly typical chronic pancreatitic. We take it out with as little duodenum as possible, but these are not good-looking glands, and of course you wouldn't want them to be. After we remove this, it's treated like any other organ transplant. It's double bagged and it's taken to the islet lab, which unfortunately in our hospital is about 100 yards away from the operating theatres. It's an automated process, as I'm sure everybody appreciates. It's injected with collagenase, the gland swells up, and then we put it in a chamber and it's agitated, and you end up with this. That's what you end up with at the end of the procedure. All the parenchymal tissue and islets have fallen off the skeleton. And then post-digest, you get this milkshake, top right. It is quite worrying when you first start doing these procedures and you're infusing it into the liver, but you stain it with dithizone, which is a zinc stain, the bottom left, and you can see the islets amongst the parenchymal tissue. Now, one of the thorny issues is whether you should purify these. Of course, for allografting, you have to purify them because the allogenic tissue is principally the parenchymal tissue, and you can purify them on a Kobe, which is the machine, which is a differential gradient. And what you do is you get a whole load of fractions, bottom left there, and you take the richest fractions off. The problem if you do that is you do lose an awful lot of islets, and I'm going to come back to that because I think it is important. The islet details, these are the islet counts we have. If you look at the islet equivalents per kilogram, which is the 4th column, these are nowhere near enough if you were doing an allograft. They would almost laugh at these. But in an auto transplant, because you get better implantation and no rejection, obviously, then often these are sufficient, and they're sufficient to produce a good quantity of C-peptide. We don't purify these anymore. We did purify them at the beginning, but I am going to discuss that later. Now, where do we put these islets? When we first started doing it, we put them into the transverse mesocolic vein, which is the left-hand slide. We did try to put them into the spleen because there's some data suggesting in large animals that if you reflux these into the spleen and clamp the draining vein for 3 minutes, then they will stay there. And from metabolic and physiological points of view, that's quite a good sight. However, We did this, and the problem is that the only veins in the human that don't communicate directly with the splenic vein, we did some cadaver studies, are the top 2 short gastric veins, and getting a cannula into one of these is not terribly easy. And we had the second patient, the first patient did very well, the second patient at midnight after the operation, the spleen ruptured. We had to take them to theatre, and we thought we'd wasted all the islets because we had to take the spleen out, except the lady turned up in clinic 6 weeks later off insulin. So what happened was we got the pathologist to look at the spleen, and there were no islets in the spleen at all. And all we'd done is find an extremely complicated way of getting it into the portal vein, so we abandoned that procedure. We now use the recannulated umbilical vein, which is the one on the right, and the advantage of that is we were very keen to measure a number of things that hadn't been looked at, portal pressures, and I'm wondering whether we could use this potentially for therapeutic purposes later on to aid implantation. And it really is very straightforward. This is the umbilical vein. It's a great big thing. So if they haven't had previous surgery, we dilate this, and we've always wanted to put the islets into the left-hand side on the basis that if it went badly wrong and there was a problem with the liver, we could at least just sacrifice the left-hand side. It hasn't happened, but the access to the left-hand side via the umbilical vein is very straightforward. So this is what it looks like on the left. You're infusing this into the liver, and when you first start doing this, it is a bit alarming, and we were very concerned to know what happened to the portal circulation. So one of our nurses doing a PhD, the ones on the left are intraoperative portal venograms, and the ones on the right are portal venograms at a week. And we showed these to the radiologists, who said the ones at a week are virtually normal. It'd be impossible to tell they'd had an islet transplant. So this is a huge area, and that was a great relief. Because we do have some ultrasound abnormalities. If in our hospital, when these people are scanned and follow up for the bilioenteric anastomosis, then the sonography will say, had an islet transplant, left-sided liver abnormal. So the top left is a normal-looking liver, and the others on the top are abnormalities you detect with ultrasound in people who've had an islet transplant. The bottom one I show because this is the same patient 2 years apart, and the appearances are virtually identical. And we have never, since 1994, had liver function abnormalities that we can attribute to the islet autotransplant. So I think from that point of view, it's very safe. So we were keen to know that the portal pressures, because originally we used a volume of digest, then we started to use portal pressures, and we wanted to make sure that these came back down to normal. So we used the umbilical vein and we transduced the pressures on a daily basis, and you find that by day 4 or 5, the portal pressure has reduced back to normal, which again is extremely encouraging. And we could use that cannula for therapeutic purposes if we needed. So we're coming back to whether we should purify or not. This slide shows what happens when you purify. At the top line is pre-purification and the bottom line is purification. Now this is from an extremely good unit. You are going to lose about 50% of your islets if you purify. You never have digest if you don't purify it, where you have to throw away 50% of the volume. So in simple terms of islet numbers, if you don't purify, you are going to get a greater number of islets, even if you throw away some of the digest. In addition, when we looked at ours, if you look at the bottom left, that is an islet that's embedded in a mantle. It's got exocrine tissue around it, and there's a lot of cell-cell interaction, which is actually valuable for the islets. We know if you over-purify islets, they do not work very well. And on the right-hand side is an islet that's been exposed and is starting to cleave. Now, when we looked in our series, the greater the percentage of cleavage, the less chance of you were of being insulin independent. So purifying these islets was not doing them any good. And in addition, we had a strange thing. We had some patients that I'll come back to, but there are a number of intermediate cells, not islets, not parenchymal tissue, that can produce a little bit of insulin and actually are under metabolic control. So if you look, there's ductal cells, glucose-positive cells, a whole load of different cells. And we looked at these because we had a couple of patients who'd been on insulin for a couple of years who suddenly we had to stop. Two females, both in their 30s, and we couldn't understand this. We said to them, have you lost weight? Have you started playing tennis? What have you done differently? Are you eating differently? No, we've not changed anything. And we suddenly start to have hypos. So something had happened to them at 2 years. So we looked at this. Now, if you look at the cells that can actually produce insulin, if you look at ductal cells, if you look at cytokeratin 19, which is an indicator of mesenchymal to epithelial transformation, if it's positive, then you're more likely to become insulin independent. And there's several other cell types. If you look at PDX, which is homeobox, or this is related to islet function and islet development in neonates. If you look at this, if this is positive, then you're more likely to be off insulin. And it seems a number of cells, glucose-positive cells, if you look at these, if the glucose-positive cells are present, or the higher the number, the more likely you are to be off insulin. So these are not islet cells, these are other cells. And there's a thing called intermediate cells. So as I say, we had a couple of patients who needed to stop insulin. We also had one patient with a ridiculously small number of islet equivalents per kilogram. That no islet allografter would ever believe that if you had less than 1,000 islet equivalents per kilogram, you could be off insulin, but she was. So we started to look at intermediate cells. So we've got a normal pancreas on the left, then we've got a chronic pancreatitis pancreas with insulin production, and the right two slides are intermediate cells. These are cells that stain positive for insulin production, which are not islet cells. And we think these are quite important in some of these patients. And if you look at them, they're scattered around amongst the chronic pancreatitis. The more of these there were, after the digest, the more likely the patients were to remain off insulin for a long time, or for their insulin requirements to degrade more slowly. Now, what about the clinical results? Well, it's a bit of a myth that you can take the pancreas out and stop their painkillers. It takes a long time. And many of these patients are addicted to painkillers. And in the early days, particularly things like pethidine, this was a real problem for us. Now that we're using tramadol and different painkillers, it's becoming easier. But often the patients would turn up and we assess them for whether they're on opiates. And they would tell us, I don't have any pain from my pancreas, but I tell my doctor I've got a bad back, I can't stop my pethidine. And that was a bit of an issue. There's nothing we could do. We had to register them still on opiates. But eventually, we get virtually every patient in the series off insulin. And partly, I think, in the UK, because it's a tiny place, the patients get sent back to us. So they get followed up by us in the clinic every time. They don't get looked after by anybody else. And I think that's quite important as well. If you look at the glucose tolerance, it does degrade with time, but it's degrading with everybody in this room with time as well. So the glucose tolerance top left at 0 and 2 hours, they do over time degrade, and that goes along with the HbA1c, which is the top right. But the HbA1cs are really very reasonable in these patients, even after 10 years. And of course, any level of C-peptide production protects you against hypoglycemic unawareness. It protects you against a lot of progressive signs, so it's very valuable. And there are some series where C-peptide production falls off, but that's different countries. So this is C-peptide over time. The basal C-peptide continues, but the stimulated C-peptide falls off. But as I say, in every single patient we've followed up, for as long as we follow them up, we have some C-peptide production. And this is an interesting slide. So what we did was we looked at the earlier patients, those are in red, and we looked at the patients in blue. Now, the patients in red had purification, the patients in blue didn't. And if you look at the ones in blue, no matter at what stage we look at them, 1 year, 2 year, 3 year, 7 years, the insulin production is better in the patients who were not purified. So as a consequence, we've stopped. Now, we do survey these patients because obviously the important thing is whether the patients are happy with the procedure. We send out a questionnaire to all these patients. We do that routinely. We've got a nurse specialist who knows them all, so we have a fairly good feedback. They're kept simple, they're kept brief. They don't all answer them, of course, but we send a second round of questionnaires and we can normally get 80 or 80% plus response, which is really very impressive for this type of patient. And the question we ask, this is the principal question, do you think you've benefited from your total pancreatectomy? And you can see from that, definitely yes is over 90%, is nearly 90%. Mostly yes, mostly no, not at all. We had nobody in the series. So that was very encouraging. And you can see that there's a reduction in their pain scores. There's a reduction in the hospital admission, both the duration and there are some patients still come back in, but they're in for very short periods and they're in far less frequently. In our series, we've had patients prior to the procedure who've had more than 50 admissions to hospital a year. And that's dramatically reduced. So patient follow-up, we do ask them again, the question as to whether they're still satisfied. Sorry, that's right. And this is a similar series from an American group, just to show that our findings are similar to theirs. If you look at the left-hand column is preoperative status, and the right-hand column is postoperative status, and they're very similar findings. No matter what you look at, global health, back to work, pain, they are improved. The selection of the patients is very important. You can't do it to every chronic pancreatitic, but if you get it right, it works very well. And just to show this, so every year, our department raises money for research by cycling. The UK is not very big, but that blue line is where we cycle, and that's about 100 miles, which is a reasonable way to cycle. And the whole team does this, and we have a team of doctors, we have patients, we have pharmaceutical people, we have research fellows. Now, that's the end of that cycle ride. And in that, he has had a pancreatectomy and islet autotransplant, and he cycled 100 miles. He has had a pancreatectomy and islet autotransplant, and they cycled 100 miles. These patients are very fit after this procedure. It does not inhibit them. And they can do that, and because they're producing some C-peptide, their blood sugar control is much more relaxed than somebody who's had a total pancreatectomy. We've had trouble with funding in the UK, but some of the things we've had to address are quite interesting. Originally, we just used to telephone the public health officer, and they would say, yes, that seems reasonable to me. Then they introduced a thing in the UK called out-of-area transfers, where we had to fill out a form. Then they introduced a thing called non-contractual referrals, where we had to fill out a bigger form. Then they introduced a thing called primary care trusts. The primary care trusts were given money by the government, and they could decide what to spend it on, and they thought islet autotransplantation was much too expensive, so they'd rather spend it on hip replacements, and basically stopped funding it in 2011. So I'll leave this slide up. This is a very old slide, because we started to apply for national funding in 2011. And I put this slide up at the time, so it was a consortium between Newcastle, Oxford, Leicester and King's. The reason we did that, those are the only units that could do the surgery plus the islet preparation, and the geographic distribution of the population worked out well. But I put that slide up, hopefully starting 2012-13. So I keep that slide just to remind myself how long ago it was. Because we managed to convince them, because chronic conditions are very, very expensive. This is a nice American Public Health Association. You can see that chronic pancreatitis is not one of the top costs, but heart disease, cancer, COPD, hypertension, diabetes cost billions of dollars a year. And by 2050 in the United States, it's going to be costing, for them all put together, trillions of dollars a year. Chronic diseases are extremely expensive. So we wondered whether we could work out the cost. Now, we have very good direct costs. I can tell you exactly how much the patients who are sent to me have cost the NHS, because I can get their notes out and their drug charts. I, however, cannot tell you the total costs, because we don't have any way of assessing their loss of time off work or early retirement and pension and bits and pieces. But the Americans do, and some of the European countries do. So what we did was we looked at the incidence in the United States, and we looked at the incidence in the UK, because there was a fantastic study from DiMagno published in 2006 based on data from 2000 that looked at the total cost of chronic pancreatitis in the USA. And what we did was we found out the increased population up to 2014. We've looked at the change in the cost of the ratio of the dollar to the pound, and we were able to work out from that, extrapolating, assuming that the United States was a reasonable model for the UK, we were able to work out that it was costing about $22,000 per annum per patient in the United States. And because we hadn't got good data for the prevalence in the UK, it was costing somewhere between £25,000 and £45,000 a year per patient, which meant that on a economic basis, we could justify this. And that's interesting, because this is a slide that I used, also an old slide, from IHPBA in 2011. These aren't the only three series, but these are the three longest series. Obviously, David Sutherland is the godfather of islet autotransplantation. We had the second longest series, and Chicago had a long series. Those are the three series showing very similar results in terms of islet isolation numbers, length of stay, hospital problems in theatre. They were all very similar. There were three long series. But in 2013, the American insurance companies decided that islet autotransplantation was no longer an experimental procedure and should be offered routinely. So this is Greg Beelman's more recent paper, and there are now about 14 units in the United States offering this procedure, because it's accepted that it's cost saving. This saves you money. If you get this right, the patients are better and they don't burden the healthcare system. There have been some international developments as well. As I say, David Sutherland and the United States clearly lead in this. We have a long experience, not that big a numbers, but a long experience. Australia have recently started a program very successfully. We've been to Scotland. Scotland has just done their first case. 2 cases have been done in Norway, and the Dutch, we're hoping, will be starting soon. So there is increasing enthusiasm for this procedure. So we went to the government. So as you remember that slide, we started in 2011. I can tell you happily that this is the NHS clinical commissioning policy. And just recently, they have decided that they will routinely commission Islet autotransplantation after pancreatectomy in the UK. So NHS will routinely commission the specialist treatment in accordance with the criteria. And that's a big breakthrough, and it took 7 years to do that. So I'm just going to try and show a video. We've had a bit of trouble running this, but I think it says it's a much better example, gives you a much better idea of what's going on than I ever could. This is a young girl that was done in Adelaide recently called Chelsea. She's happy for us to show this video. She's had chronic pancreatitis since the age of 10. She's SPINK and PRSS abnormalities. This video shows her 10 weeks following a pancreatectomy and islet autotransplantation when she goes back to her sports club to meet some people, and they're obviously very supportive, and they made this video to surprise her.
Ashley, how long is the video?
It's about a minute, but it's not going to run. It's not going to run anyway, Thierry. Okay. I'm sorry about that. So, but she's 10 weeks afterwards. So, in conclusion, this is a safe procedure. If you select the patients correctly, it's a good procedure. The mortality is very low, and I think it should be offered routinely in selected units for selected patients. Thank you.